And now, Ruth, it takes me back to the same question I asked a second ago, but now that we delve a little bit in more details in regard to the side effects for the therapy, and that kind of sorafenib followed by regorafenib with all what you mentioned in regard to the potential side effects, or at least the most common of which, do you think this really something that you'll be able to circumvent and convince the patient that's totally appropriate to do that approach of therapy, or are they going to look a little bit more into the checkpoint inhibitors as being the aspiration for to get on? Like, just how can you support a sorafenib followed by regorafenib with all what we just heard about side effects?
Yeah. So first, I think if you look at the efficacy point of view, nivolumab it's an active agent. So usually I would want to have the patients being exposed to all therapeutic options if possible. And if patient's liver is on the verge of patient is very symptomatic from the cancer, then sometimes I would move to nivolumab earlier. And usually I will look for early signs of progression, and then just make sure patient has a good chance to get on all therapeutic options.
Fair enough. And Anthony, this brings me to the same question regard to Nivo. You're right, the excitement about the checkpoint inhibitors is really overwhelming, but nonetheless, the news about the potential side effects from the nivolumab are definitely more heard of nowadays. And how can you assure a patient that the side effects are definitely there, but will be able to manage them, but at the same time, like, how common are they in regard to the really severe ones? Like, what will be your way to convince a patient to go on the checkpoint inhibitors if it is the appropriate therapy for that patient?
Well, if it is the appropriate therapy, I think my message is usually that the majority of patients in reality don't feel anything when they're getting a checkpoint inhibitor. We're mostly noticing these laboratory abnormalities, and maybe if they've been on a while, maybe a little bit of fatigue. But most patients, the large majority, don't feel much. I do tell them that there are potentially severe side effects that can be life-threatening. Certain autoimmune diseases in certain organs can be life-threatening. So we have to watch carefully for them. When there are symptoms that could be indicative, let's say, of pneumonitis, that an appropriate workup is done to make sure it's not something else. So it's important to not assume that every symptom is an autoimmune complication as well. So an appropriate workup be done, and then appropriate therapy with steroids be instituted in a timely fashion. So that's how I reassure them, that we know what we're looking for, and then if anything unusual starts happening in a specific organ site, like more diarrhea, more cough, etc., you alert us and we will look into it. And I think that's just physicians have to be aware of these potential complications.
I'm glad that you bring up that. Thankfully, more commonly than not, patients will be okay, and thankfully there is a certain rarity to the potential of serious side effects. But tell us from your experience, like, what's like a real bad thing that can happen?
Well, so the autoimmune pneumonitis and colitis, I believe, are among the more common autoimmune complications, and I think we've learned how to treat them relatively well. I would say that some of the more rare things like myositis and encephalitis, and those tend to be a bit more complicated, and I think the track record in knowing how to control them, maybe the information is not as common and not as available. We still follow the same principle of steroid therapy, but my impression that inflammation in those other sites beyond the lung and colon sometimes can be a bit more concerning. And we require a bit more aggressive management.
Sure.
Potentially.
So if anything, we heard here a incredible detailed discussion about two new advents of therapy, being the regorafenib followed by sorafenib, as well as nivolumab. And if anything, we did hear a great acknowledgement about the benefit of those two therapies. The regorafenib definitely has an improvement in survival compared to the placebo after progression on sorafenib. And we said that sorafenib followed by regorafenib can together probably join into an improvement survival for up to more than 24 months. On the other hand, we heard about the incredible response rate that can occur with the nivolumab, that again, to reiterate that we suggested that this will be close to about 20%, and same time we said this is already approved. But more importantly also, we heard quite a bit about the potential side effects that can occur with the different kinds of therapies. And again, to re-summarize, the head foot syndrome, the fatigue, the diarrhea that can occur with the checkpoint inhibitors, I correct myself, with the TKIs being sorafenib and regorafenib, are very important to make sure we catch early, we manage early, and to adjust the dose accordingly. On the other hand, we heard about the most commonly lack of side effects with regard to the nivolumab, but nonetheless they can occur as well. And as we just noticed, that the allergic reactions in regard to the skin, in addition to that, the potential colitis, and of course the more intense things that can occur regarding thyroid, pneumonitis, and what have we. Thankfully they are rare, but it's very important to be aware of them and acknowledge them and manage them accordingly. If anything, our colleagues could not really necessarily pin down, and in all fairness, the data is not there, about like how to manage the sequence of those therapies.